I am attached also to Johns Hopkins and the London School of Hygiene and Tropical Medicine. And I have been doing health policy for a number of years. And the conference organizers asked me to make a presentation on a paper, some of the papers I've been writing, which is really how we're beginning to redefine health in terms of not only personal health, but particularly in policy and the way we address health problems. So I use this term paradigm, which I'll explain, and look at what the challenges have been brought out of redefining health, particularly in COVID. So first of all, let me define a paradigm. A paradigm was first developed and discussed by a man named Thomas Kuhn in his book, The Structures of Scientific Revolutions. And he defines it as a philosophical and theoretical framework of a scientific school of thought discipline, which in theories, laws, and generalizations and experiments performed changes the way it performed is formulated. So Kuhn's example of a paradigm is the way in which we began to look at the world not as the center of the universe, but rather looking at the sun as the center of the universe and the earth going around it. This is a classical example where one, in particularly the church, had defined the world as the center. And through scientific experiments over a century, the understanding what the world was changed. So let me talk about the historical paradigms of health. And basically for at least the last 3 centuries, certainly since scientific interventions became more prevalent and better used, health has always been defined with the disease eradication, how to cure things. But the paradigm makes it very linear, predictable, and focused on outcome and impact. So if you ask most people what health is, they will tell you it's the hospital next door. But this paradigm has been based on scientific construct, where the basis of it is that any outcome has to be reliable, replicable, and valid. And that's why the case control studies have been the gold standard for health improvements. However, after World War II, and with the creation of the World Health Organization, and because of many factors that led to the decimation of lots of the world, including particularly Europe, there was the UN was created, and the constitution of the World Health Organization, one of the UN organizations, defined health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So it began to define health outside merely the disease control. However, it's been some time to see this develop. And about 30 years later, again, the World Health Organization in its conference in Alma Ata described primary healthcare, which took health not out of the hospitals and medical provisions into equity, social justice, and community participation. And again, the policy of this was promoted in the WHO Commission on the Social Determinants of Health, which defined health as a means toward good and global health, not simply health services at the primary level, though it was important, but a health systems model that acted on underlying social, economic, and political causes of poor health. So the shift of looking at health as just merely looking at and solving disease and hospitals and doctors has been taken into a broader definition. this is in theory, this is the vision that the World Health Organization and its members saw as defining health. However, as you can imagine, there was quite a pushback in trying to translate this policy into practice. And two examples of this pushback was certainly after the first the WHO meeting, that two professors from Rockefeller defined the term primary healthcare, saying it's all that's a vision and we should all hold it. But the practicality is that we really need to be focused. And so they defined selective primary healthcare, which focused on care that diseases had the highest prevalence of mortality and morbidity, the highest risk of mortality, and the possibility that they could be controlled in terms of cost effectiveness of the intervention. And so primary healthcare became focused basically on service delivery and mainly at the local level, trying to get people who didn't have the opportunity to get good care, some type of care. That was in 1978. 30 years later, at that Scientex Conference, primary healthcare was included and focused on universal healthcare, which was the idea of getting money to provide services, so equity and concerns of particularly those who could not get services would have access. The challenge of universal healthcare was that it focused on financial support, not on the delivery of services or how health could be improved. So there was a pushback against the new paradigm, the WHO paradigm, as you can see. But even though the World Health Organization members agreed to this, there was a resistance in practice. And one of the things for particularly the developed countries were arguments put forth by a Johns Hopkins professor, Barbara Stuffield, who said, primary healthcare is valuable for low and middle income countries, but to the developed countries which have strong health systems, we need to focus on delivering necessary healthcare. And if you go today and do a literature search on the term primary healthcare, you'll find that most articles focus on the services at a local level. They don't consider things such as participation, equity, as part of what they are developing at those in the service delivery. So let's look at the COVID experience, which has brought in a lot of challenges to getting people protected and cured. And what has this said about the way in which we've seen the biomedical intervention as key to controlling COVID? Well, we know it didn't contain the pandemic. And we also saw a resistance to the scientific and professional advice of control by people who, as you know from your own experience in your own country, are rejecting vaccines and masks. And no matter the scientific proof has not broken that resistance. Also, we've seen with the COVID and the challenge of trying to control COVID that the whole question of equity has not really been addressed. And you can see that particularly in the vaccine distribution, because the people who get the vaccines are the people who have bought it from the developed countries. And there's a great lack of this distribution, particularly in Africa, which I've been following, and in other developing countries. Countries that had very good control, like South Korea in the beginning, now have COVID cases have gone up because so few people are vaccinated. So the question of equity of who gets these vaccines and other interventions has certainly questioned the value of health in just in a biomedical term. And the paradigm, the biomedical paradigm, does not address critical issues of governance, law-based approaches, and the social determinants of health. One which must address equity, participation, social determinants of health, and begin to see these health interventions as a process, not only as an outcome. And the World Health Organization, once again, as a leader of articulating these values and views, has developed a new focus for their approach, in which they, and I've shown the graph there on the right, have looked at multi-sectoral policies, empowerment of people and communities, and primary care and health, public health functions. And it says PHC is rooted in a commitment to social justice, equity, solidarity, and participation. So once again, the rhetoric sounds very good, but will we see any movement? And you can point to some movement. For instance, the concept of One Health is now becoming very much looked at and implemented in certain cases, where it's a collaborative and multi-sectoral and transdisciplinary approach, working at the local, national, global levels to achieve optimum health outcomes and recognize the interconnection between plants, animals, people, the natural world in a shared environment. And that's one type of program and focus that is now coming very much into the dialogue. And another is the planetary health, which the Lancet has promoted, which is the achievement of highest attainable standards of health, well-being, and equitable distribution worldwide through judicious attention to human systems, political, economic, and social, that look at the future of humanity and the Earth's natural systems that define safe environments within the limit which humanity can flourish. Put simply, planetary health is the health of human civilization and the natural systems on which it depends. So you've got these two focuses now of expanding health beyond just control of disease and services to try and integrate this. And those are the policy views of that. What are we seeing in practice of actually implementing this wider view of health? The National Academy of Medicine in the US has just published an article in the Lancet and says that one of the challenges is changing the medical school curriculum, because people who go to medical school are not taught about these wider things. And it's critical now that we look at social determinant ethics and equity. And this had these ideas and approaches need to be brought into the medical curriculum. And I've just published an article, which, and there's a reference list at the end of this, talking about how we need to break the silos of health services, universal health care, and community participation, and integrate them to the clinical and the public health functions of health into a much broader framework. But what are the chances of this happening? Well, as we heard earlier, the power of the professional is pretty strong, and because of the protection of their money and their prestige, there's a pushback of taking the concept of primary healthcare, translating it into deliverable services. And that is still a major factor in how we begin to expand a different definition and a different approach to health. And there's also a problem, as I just mentioned, in the lack of training in medical schools to approach a wider understanding of health and looking at equity, community participation. And the third question is, of course, is the speed of the new technology, which telemedicine, new information, new treatments, all these things are a pushback between broadening a concept of health and keeping it very much in the traditional biomedical paradigm of service delivery and disease. So, in a conclusion, I just want to say the Kuhn, who wrote about paradigms, that says we have all these arguments and information. It is about changing paradigms, but the paradigm change is not inevitable. For the world to accept the idea that the Earth was not the center of the universe and it revolved around the sun took a couple of hundred years. Communication today would certainly shorten that time, but it was a long push. And Galileo, who was one of the scientific people on this, spent years in prison for suggesting there was another interpretation. Where paradigm changes are new changes is where people are getting greater acceptance of these new views and putting in policies to accept these new views. But the opposition by those who hold an old paradigm is very strong and needs to be overcome. And there cannot be two paradigms at the same time. A paradigm only emerges when the old one is rejected. So I've given you a list of references here, and on my first screen I have a Gmail if you'd like to follow up on some of these things. And now if you have reflections or questions, please do so.